It has been an exhausting session, so I will skip most of my slides in this because a lot of revision has happened. So the challenges when we have a periprosthetic fracture, like the fracture scenario, is not only getting a sound, solid healing, but we have to take into account the prosthesis that is already existing, and if it hasn't loosened, we shouldn't cause any loosening in our procedure, as well as we don't change any alignment for these prostheses, whether it may be a knee replacement or whether it's a hip implant. So the alignment comes into a special challenge when we have a periprosthetic fracture. So fractures that occurs across associated with joint prosthesis, maybe because of trauma, osteoporosis or osteolysis. Treatment is complex because there is already an existing prosthesis which may be loose, which may not be loose. There is also cement involved, which again has a challenge when we decide on the fixation. So prevention is always better. Surgeon having a good understanding and the principles of fracture fixation is not sufficient. They also need to take into account the alignment of the limb, especially in the lower extremity, because any malunion or malunion can give disastrous problems for the prosthesis longevity-wise. So epidemiology-wise, 1% after primary total hip arthroplasty and 4% after revision total hip arthroplasty, periprosthetic fractures are documented. 75% are due to low energy trauma, whereas in a total knee replacement, 0.3 to 5.5% after a primary total knee arthroplasty, whereas 30% after revision. And the most common periprosthetic fracture is supracondylar femur. So I don't want to go into all these patient-related fractures. We all know, as at this stage, osteoporosis, small size, strong stature patients, pre-existing deformity, lysis, prior surgery defects can all be one of the causes for the periprosthetic fractures in a hip. Classification, intraoperative fractures and postoperative fractures, we describe and approaches accordingly. When we have an intraoperative fracture on table, how do we address that, and postoperative fractures, we have enough time to plan and execute those fixations. So intraoperative fractures, the mechanism is especially for proximal fractures, we divide it into proximal fractures, middle fractures and distal fractures. Proximal fractures usually occurs with bone preparations. So especially these bones are osteoporotic, and then aggressive rasping, and the way we insert the prosthesis or hammer the prosthesis after the broaching may cause implant insertion for dimensional mismatch. So middle region fractures occur usually when excessive force is used during surgical exposure or bone preparations, and distal fractures usually occur when tip of the straight stem prosthesis, non-anatomical implants are used, impacting of the without considering the femoral bow. So these are some of the fractures that we may miss out during the surgeries. Risk factors, impaction of bone grafting, female gender, technical errors, cementless implants because we need to hammer them, and osteoporosis, mainly revision, minimal invasive techniques can also lead to periprosthetic fractures. So change in the resistance while inserting many of these uncemented implants should always raise our eyebrows or suspicion of intraoperative fractures. So classification wise, I don't want to go into all these things which has been discussed by our previous authors. Coming to options, these are the various options which have been discussed, and mostly additional plate is preferred so that we have a better rotational stability as well as anatomical reduction without causing any variation in the angulation of the prosthesis, proximal or distal. So here's one more case of already well secured or a stable bipolar hemiarthroplasty and long spiral fracture at the tip of the stem. And in this situation, we are lucky in the, like the previous authors who had a long plates, we are having this blade claw plate available as much as length as we want, and with minimal morbidity for the patient, we are able to mobilize him after the surgery. Similar fractures which have been fixed in the past, and we have a blade plate which we have discussed in the previous by the previous speakers. Periprosthetic fractures coming to the knee replacement can occur mainly in the supracondylar region of the femur and tibia as well as the patella. The timing of intraoperative medial femoral condyle fractures most common and post-operative. So risk factors again here, poor bone quality, age, patients who have been on steroids, rheumatoid arthritis, where there is stress shielding and neurological disorders. Mechanical stress risers, there is already existing screw which causes a stress riser effect, lysis around the implant, stiffness. Distal femoral fracture classification, 0.3 to 2.5% incidence is there. So this is the fracture based on the classification what we have used, type 1 fractures and type 2, type 3, and these are based on how distal the fracture goes to the prosthesis and whether the prosthesis is loose or not. So tibial periprosthetic fractures, incidence is 0.4 to 1.7%. Fracture risks are mainly prior to the tibial tubercle osteotomy, component loosening, component malpositioning, and insertion of long stem tibial components. Felix classification, as we know, where the prosthesis type 1 is undisplaced tibial component and just a fracture, then at the tip of the fracture, and 3 and 4 where the fracture is distal to the tibial component. The type 4 is where the tibial tuberosity is avulsed. Treatment non-operatively for undisplaced fracture remains the same with stable prosthesis. For open reduction, we have to have the unstable fractures, and with the stable prosthesis, long stem revision prosthesis for displaced fractures with loose tibial components. So this is another case where the total knee replacement components are undisturbed after the supracondylar fall. You can consider the supracondylar nails with, which was just discussed by our previous speakers, but if the box is closed, then that option is closed for us, and again we go back to a blade plate for these type of fixations. When you have a fracture where the femoral component is loose and you don't have any option for the fixation in this case, definitely we consider as a megaprosthesis which can solve the problem without disturbing the function of the patient. So these are the four different modalities of fixation of supracondylar fractures. The supracondylar nails, when you have an open box, you can use a blade plate arrangement when you don't have an open box or when there is a comminution, and when the component is loose, you go in for a megaprosthesis or change of the full assembly. Patelloprosthetic fractures, I don't want to go into details of this. There are non-operative when there is a stable fracture, and then we open fix the patella as per the fracture pattern. To summarize, periprosthetic fractures around total knee arthroplasty are treatable with various techniques and implants as long as the surgeon has all the implants to his dispersion, and as well as he has enough knowledge of retaining the alignment of the long axis of the femur of the lower limb after fixation. Thank you.
Thank you, Dr. Manish Samson. I will call upon all speakers for question and answer session.